Thank you for joining me on my lecture today. My name is Gabriel Allaf. I'm currently a psychiatry resident, and today I'll be presenting a comprehensive and integrated overview of bariatric surgery. This presentation will combine both the medical and psychiatric perspectives behind bariatric surgery, as well as looking at the criteria for surgery, the different types of procedures that are currently available, the preoperative and postoperative processes, and finally the long-term outcomes and challenges, especially those related to mental health particularly. There is a very large growing need for bariatric surgery, and this is because obesity is currently a global epidemic. In the United States, over 42% of adults are obese, and unfortunately, that number continues to rise. In fact, globally, obesity rates have tripled since 1975, which is an incredibly devastating number to think about. Bariatric surgery is the most effective intervention we have for long term, sustained weight loss and core morbidity resolution. In fact, these procedures not only reduce patients' weight, they also significantly improve or resolve conditions such as type 2 diabetes, sleep apnea, hypertension, and or hyperlipidemia. With over 250,000 bariatric surgeries performed annually in the United States alone, this is truly a crucial area of modern medicine. In 2022, the criteria for bariatric surgery was updated by the ASMBS, or American Society for Metabolic and Bariatric Surgery, and also the IFSO, or the International Federation for the Surgery of Obesity and Metabolic Disorders. They updated the criteria to reflect that patients with a BMI greater than 35 may now qualify regardless of their comorbidities. In addition, the criteria reflects that patients with a BMI of 30 to 34.9 may also qualify if they have type 2 diabetes or other uncontrolled metabolic conditions. Finally, the criteria also reflects that Southeast Asian individuals may qualify with a BMI as low as 27.5 due to elevated risk at lower BMIs due to their counterparts. These changes reflect growing evidence that early surgical intervention is more effective than lifestyle changes or pharmacotherapy alone for long-term weight and metabolic control. However, before any patient can proceed with bariatric surgery, there's obviously pre-op requirements and preparation steps that are required. Patients must undergo a very extensive preparation process, which involves a multidisciplinary team. This includes evaluations by medical, psychiatric, surgical, and nutritional experts/providers. Baseline labs are also checked in order to detect deficiencies. Patients are also expected to demonstrate engagement in at least 6 months of lifestyle modification. In addition, smoking and substance cessation are required. And finally, motivation as well as understanding of the procedure and adherence potential are also assessed by these providers. Truly, the preparation phase is crucial in order to set expectations and also improve long-term outcomes. A component of the evaluation is both the medical and behavioral evaluation. The medical evaluation itself will include an assessment of comorbidities, particularly diabetes, sleep apnea, and cardiovascular risk. Labs can include, but are not limited to, hemoglobin A1C, lipids, thyroid, and sometimes liver enzymes as well. In addition, a sleep study may be indicated, and medication review is vital, especially identifying weight-promoting agents that the patient is currently taking. Behavioral Ultimately, the patient must be assessed for their readiness to change, ability to follow complex medical regimens, and also be assessed for the presence of support systems. There is quality of life tools that can be useful to document both impact and progress. So now the psychiatric evaluation prior to surgery. This is very essential to identify conditions that may compromise outcomes or patient safety. This is including but not limited to major depressive disorder, anxiety, PTSD, OCD, substance use, and binge eating disorder. In addition, part of the psychiatric evaluation is assessing for cognitive capacity to ensure informed consent. Also, the provider has to examine past and or present suicidality, psychosis, mania, and personality traits such as impulsivity and non-adherence. In addition, trauma history is also very important, especially childhood abuse, as it can influence eating behavior and overall body image. Stabilization of psychiatric illness is usually required before surgery can be proceeded with. There are several key domains of the psychiatric evaluation, and this should include a full history of both Axis 1 and Axis 2 disorders, trauma exposure, and current coping strategies. Some key questions include: does the patient understand the consequences of surgery? Are they emotionally prepared? Do they have insight into their eating behaviors? Do they see weight as protective? In addition, the provider has to also assess for personality structure, impulsivity, and how the patient handles stress. The provider also has to evaluate for a locus of control, as patients with an external locus of control, in other words, blaming others or their fate, often struggle with post-op outcomes. In addition, the provider also has to assess and evaluate if the patient has a very strong social support, as this is very protective for the patient. So, psychiatric illnesses are actually extremely common amongst bariatric candidates. In fact, up to 70% have a lifetime history of a psychiatric diagnosis, and nearly up to 50% have an active psychiatric diagnosis at the time of evaluation. The most common psychiatric diagnoses include major depressive disorder, generalized anxiety disorder, PTSD, OCD, substance use, and binge eating disorder. Approximately half of these patients are on psychotropic medication. This underscores the extreme importance of a very comprehensive psychiatric assessment. Not to exclude patients, but in order to better understand and as a result support and prepare them for their bariatric surgery. However, this is not to say that there are particular contraindications from a psychiatric perspective for bariatric surgery. Certain conditions that are contraindicated, which are absolute, would be active substance use, uncontrolled bipolar or psychotic disorders, anorexia or bulimia nervosa, severe suicidality or recent attempts of suicide, severe personality disorders that impair functioning, and finally, cognitive impairment that limits informed consent. As a result, surgery should be deferred until these are stabilized. Obviously, policies per institutions may vary. However, these conditions generally require active treatment and need to require demonstrated improvement before proceeding. So, what is the overall impact of psychiatric illness on surgical outcomes? Is it truly that important? Well, psychiatric comorbidities have actually been shown to reduce weight loss after bariatric surgery. A study actually found that patients with 2 or more psychiatric diagnoses lost significantly less weight, actually around 10.8 BMI units, compared to 16 units in patients without psychiatric illness, which is a very large difference. Recent hospitalizations for psychiatric diagnoses or uncontrolled symptoms are also considered red flags. That said, psychiatric illness is not a contraindication besides the absolute contraindications mentioned previously, but it must be addressed and well managed preoperatively in order to improve adherence, insight, and engagement on behalf of the patient. What are some psychiatric risk factors for poor outcomes? In addition, or particularly focusing on the ones that we have mentioned previously. There are certain psychological patterns that increase the risk for poor outcomes post-bariatric surgery. This include binge eating and night eating, which are particularly concerning. As previously mentioned, a history of trauma, especially when obesity serves as a psychological shield against intimacy, as this can complicate emotional recovery. Patients with poor treatment adherence in the past are also less likely to succeed. And as previously mentioned, patients with an external locus of control may also struggle with their responsibilities that are needed post-op. And finally, a lack of social support is a very consistent risk factor for relapse and post-op complications. So what are the different types of bariatric procedures? There is the Roux-en-Y, which offers rapid weight loss and improves GERD, but also carries a risk of malabsorption. There is also a sleeve gastrectomy, which is a simpler restrictive procedure with lower complication rates and is now the most common. There is also a duodenal switch, which offers maximal weight loss but has significant nutritional complications. And there's also an adjustable gastric band, which is rarely used now due to poor long-term outcomes and high revision rates. However, in the end, the choice of procedure as well as the patient should also be very personalized. So what are the outcomes of weight loss per the procedures mentioned in the previous slide? Again, different procedures have different weight loss trajectories. So for the Roux-en-Y procedure, there is approximately a 25 to 31% of total body weight loss at the 5-year mark. For the sleeve gastrectomy, there is a respective 18 to 25% at 5 years. For the duodenal switch, there is a 40 to 74% total body weight loss. Then also for the adjustable gastric band, there is approximately a 13 to 15% total body weight loss. However, for all patients, some weight regain is expected. Usually patients will gain about 5 to 10% of body weight over the next 5 to 10 years. However, it is very important to remind both yourself as the provider and also remind the patient that weight loss is not the only goal. Metabolic improvement and quality of life gains are also very important to consider. So, what is the post-op hospital course? Well, the early post-op period usually includes 24 to 48 hours of observation, for which the patient is monitored for respiratory issues, especially in patients with obstructive sleep apnea. It is very important to encourage pulmonary hygiene and early ambulation. In addition, it is usually clear liquids are started within 24 hours if tolerated, and pain is typically managed with oral medications and nausea with antiemetics, respectively. Those with a prior history of diabetes or currently have diabetes at the time of the procedure need close glucose monitoring. It is very rare for a patient to be admitted to the ICU unless the patient has high risk features like unstable coronary artery disease or severe obstructive sleep apnea with desaturation. There is also nutritional management, which happens post-op, which actually occurs in stages. Stage 1 to 2 includes typically clear and fluid liquids with high protein. Stage 3 will then progress to soft liquids starting at 2 to 3 weeks post-op. And then stage 4, the patient will then transition to regular fluids by 6 to 8 weeks. In addition, the patients must stay well hydrated, drinking hopefully at least greater than 1.5 liters per day, and also take multiple supplements, including vitamin B12, vitamin D, calcium, and iron. It is also very important for the patients to avoid sugar to prevent dumping syndrome, which is why dietitians play a very key role in education and monitoring throughout this entire process. So now, post-op, there's also psychiatric management, which is very essential. Post-op, there's a risk of relapse in depression, anxiety, or substance use. So it is very important for the provider to identify emotional shifts, the loss of food as a coping mechanism, and changes in interpersonal dynamics which can trigger patient distress. Regular therapy, including CBT or even DBT, as well as support groups, can prevent this decompensation. As a result of the procedure, psychotropic drug absorption may also be altered. So it is important to consider monitoring levels at 1 week, 1 month, and also 12 months post-op. It should be considered to avoid extended release medications due to the drug absorption being altered. Thus, consider using liquid or oral disintegrating forms whenever possible. Now, there is also psychosocial and emotional recovery, which in total is a very complex process. Many patients grieve the loss of food as a source of comfort. Some patients may even experience buyer's remorse, especially if the results don't meet their expectations. In addition, body image dissatisfaction may also persist despite weight loss. Sorry, going back one slide. Social groups, support groups, psychotherapy, and peer mentorship are very effective tools. Monitoring for suicidal ideation or substance relapse is also very critical. In total, this is to emphasize that emotional well-being is just as important as physical health. So, proceeding forward with long-term follow-up. Long-term care is again very crucial and again must be lifelong. This includes annual labs and vitamins and mineral deficiencies, routine dietitian follow-ups, and structured physical activity, with the recommendation of at least 150 minutes of moderate intensity exercise every week. Psychiatric follow up is also required, if not recommended, to adjust medications, support emotional and behavioral health, and screen for new issues like transfer addictions. Continued engagement with a multidisciplinary care team is the best predictor of durable success. In summary, bariatric surgery is not a quick fix. It is a long term, in fact, lifelong, multidisciplinary process. Success not only depends on the surgical procedure, but it requires patient adherence to the behavioral change and ongoing psychiatric stability. It requires a full team, from surgery to medicine to mental health, nutrition, and the patient being the forefront of it all. Patients who feel supported across these dimensions are far more likely to achieve and maintain their goals. This approach reflects the biopsychosocial model at its absolute best. Thank you for listening to my presentation. I greatly appreciate your time, and I hope I contributed to your education today. Here are some of my references that I use to draw on for this presentation, including the guidelines, the current updated guidelines, as well as up-to-date articles and studies, some cohort studies. I've also incorporated insights from the Clinical Manual of Psychosomatic Medicine. In total, these sources truly highlight the necessity of integrating psychiatric and behavioral care into every stage of not only the bariatric surgery process, but also touches on the total biopsychosocial dynamic that is required throughout medicine. Thank you so much again, and I hope you have a great rest of your day.